Welcome to the Canadian Advisor Cast, podcast dedicated to financial advisors and the people that work with them. My name's Kevin Press. I'm editorial director of advisor.ca. Zaina Khayat is a Canadian health futurist, strategist, and advisor focused on how technology, demographics, and policy are reshaping healthcare systems. She earned her PhD in diabetes research and cell biology from the University of Toronto. She's now adjunct professor and executive in residence, health sector strategy at Rotman School of Management. Welcome to the program, Zaina. I heard you speak at last fall's Securities and Investment Management Association conference. You blew me away. I've been so looking forward to having you with us. Thanks for taking the time.
Well, thanks for having me. This is such an important and fun topic, so I'm keen to get into it.
You talked a lot about longevity at the CIMA conference and how the aging process for Canadians is evolving. So let's start with a broad question. What are we witnessing?
Good place to start. So 2025, Canada entered a very rare community called a nation of the super aged. There was only about 7 or 10 countries there. Japan has already been there for 15, 20 years, but that's when, more than 1 in 5 of the population are over 65. This has never happened in the history of our country and really of our species to have this disproportionate population reach this age. One metric that I threw out there that kind of hurts your brain. There are more people alive over 65 today than ever made it to 65 in the history of our species. Cumulative, right? Just marks the moment. And so with that, I used to be a chief futurist in a seniors care organization, SE Health. And so to get our head around, what are we doing? What are we designing products and services for? We co-authored a book called The Future of Aging. And in that, we looked at 350 signals that suggest something about how aging is going to happen going forward in society looks almost nothing like what it's been. And it kind of organized itself into 5 big themes, those 350 signals. The first big one is the identity of aging, like the social construct of aging. And a good analog, Kevin, is if you think of what sexism has been through, what racism has been through, that's coming for ageism, which is this is emancipation from a whole set of social constructs. That then unlocks the next big 4 areas, the economics of aging, which I think we're going to get in, labor force participation, saving, investment, all the, spending money, the housing and kind of community aspects of aging, of course, healthcare, and then how older adults relate to technology in the new era.
Before we get into all of that detail, we talk about longevity and health as kind of synonymous things, but they're not necessarily, are they? Just Canadians are living longer, but are they healthier than they were, say, a generation ago?
You're spot on, Kevin. I think it's a factor of a very easy KPI to measure as a barometer, like a composite index of the health of an entire population, is life expectancy. And that's been the KPI for the last 100 years. It's a really great way to rack and stack Canada or a province or a city against everybody else, because it's a pretty objective measurement. But yeah, lifespan is not health span. And that's a major shift coming, that we are now able to quite objectively measure health span, which is, again, the health in your years, or the life in your years, not the years in your life, which is lifespan. And so on life extension or life expectancy, yes, it's getting longer and longer on average for anyone in the West. The only country reversing lately has been the United States. And that's because the low-hanging fruit are getting plucked. Like we now, HIV is a chronic disease. Most cancers are now a chronic disease. We can extend life with Alzheimer's. We have less accidents. We've done great jobs on sanitation and all those great things. So those continue to push the frontier, but definitely not seeing the same result of health span. matching lifespan. And so that's a bit worrying. And that's why a lot of us that are trying to fix our healthcare system, we're trying to, at least bend the curve of some areas that are actually getting worse: cardiometabolic illness, mental health. And then because we're staying alive longer, our rates of acquiring cancer, Alzheimer's are going up because we're around to get those diseases. So a lot of those factors are affecting health span.
This is all really important for financial advisors, our core audience, because it impacts retirement planning and specifically the planning for health expenses. What do advisors need to understand about how all this is evolving?
Okay, so let me kind of unpack those words, right? So, I like to give this word aging well, everyone likes to throw around. And then maybe, Kevin, what's in your brain when you think about that? Or if one of your advisors is meeting a client, what your advisor thinks aging well is not what the client, but a bit of an objective definition is maximizing and aligning your client's health span, wealth span to their ever-growing lifespan. Okay? Now, those three metrics, health span, wealth span, lifespan, are completely out of whack. All right? Lifespan's about 81 years in the OECD and growing. Health span, which is the number of years you're in good health, is about 63 years. And then wealth span, which is whether your money survives as long as you do, it's off by about 10 years to lifespan. And so that gap of those three not aligning, is like a $1 trillion plus annual kind of protection gap in terms of people's, let's call it unfunded retirement costs. So, those would be the things as advisors they want to be thinking about. I can get into a lot more details, but that's kind of at a high level.
I love that. So my first takeaway from what you're describing is we need to really understand health expenses as part of a retirement financial plan, right? That you really cannot think of those two things separately.
Not at all. Like, there's regular inflation and it's, in a weird, funky state right now. But yeah, with these longer lifespans, they are going to come with much more debilitating and very, very costly like medical conditions and these amplifying needs for support. So if you play it out like 20 or 30 years, I don't know anyone in Canada who thinks our publicly funded system can support that level of debilitation. We're going to peak in terms of the boomers aging out at about 2040. Like we are on a ride, Kevin, till 2040 of demand far, far, far exceeding, our public capacities to pay because our tax base is pretty fixed and constrained and demands on exponential. So, being able to meet the costs of like public care and nursing homes or at home is going to like triple or quadruple in today's dollars. Unpaid caregiving, where your children or the dependents provide 75% of the care, right? It's the number one health workforce in the country, by the way, is unpaid care workers. That's going to have to go up, 40% to double in the next year. So, all these levers, we're seeing Canadians are really not prepared for the degree to which their costs of care associated with aging will be borne by them. And then, because we've been accustomed to thinking it's free, right? And we've been a bit like proud of ourselves that we're not the American system where you have to pay at the point of care. And so I'm expecting the whole wealth management space and government and policy is going to look for ways to get Canadians who are wealthier to pay a lot more for their care. So, for example, we means test on income. Think of that like cash flow, Kevin. I think we're going to start means testing on wealth, right? Because means testing on income isn't closing those gaps. And, you add on top of that, older adults over 60 are increasingly accumulating significant debt and even going into the red. You can then start to see where, like, those metrics I gave you about lifespan, health span, and wealth span start to widen even more. And the toolboxes we have to address that will be insufficient.
So let's talk about that a little bit more. Means test based on wealth. I assume that what you're saying there is that we can't count on government to expand its healthcare spending for the aging population. So therefore, the sort of government solution, for lack of a better term, is to think about different ways of having consumers fund their own healthcare needs. Am I reading that back to you correctly?
Yeah, I don't know if it'll be necessarily there are some echoes that this will become policy, that it's just not possible. What do we want? Because you've got fixed and constrained supply, which is based on taxation, right? We finance in Canada 70% of all of our healthcare through taxation. Well, if your taxation isn't growing up, unless somehow we magically win in the AI race, Kevin, something's got to give. And what's been giving today in Canada, because that supply and demand is already really out of whack, is 6.5 million Canadians don't have access to primary care. We wait 12 months, 18 months, sometimes 2 years to see a specialist. We are waiting 2, 3, 4 years sometimes for like an elective hip surgery or knee surgery. And there's just a lot of things we don't have access to in this country because we have to ration care. And so already those who have means have to fund their own aged care. But more and more that might start to be a policy directive just to free up the ability to do kind of medically necessary services, such as, if your kid got a very dangerous disease, we want to make sure the system's there for that. So a little bit of both. Like the market will create solutions because the system isn't there, and the system might start to do some policy to shift the role of consumers in funding their own aged care.
Are Canadians ready for this shift? I mean, it's from your description, it's happening in real time. So maybe the question is, how are Canadians adjusting?
Look, between the accumulated debt, even if none of these changes were happening in terms of us accumulating illness and staying alive longer, the gap between cash flow available, and the amount of time we're alive is still there, right? Canadians, the numbers better than me, are not major savers. Like, for example, the country of Singapore, where it's just in the DNA to be putting away your personal wealth. So what we're starting to see, and this is a global phenomenon, but coming in Canada is, I say this shift from retirement to rewirement. And some of that is by necessity, that they actually, need to keep working to be able to finance whatever costs to stay alive longer. And that's certainly a big case in the US. But others are going from retirement to rewirement because they want purpose. And they feel good, and they've got a lot to contribute, and nobody's going to arbitrarily tell them when to retire. So I think that force is a big one in terms of having a little bit of buffer to shift the dynamic of the wealth span part of the gaps that we have. And then I think there's a lot of tools coming that are going to allow us to maximize our health span in a way we just were not available to us in the past.
I'd like to come back to that, but a more general question first. How are seniors doing, do you think, both those who have fully retired and those who are somewhere in that gray space of what we call sometimes unretirement?
Yeah, I mean, I think it's a tale of two, maybe 25 worlds. But, on the one hand, in our book, The Future of Aging, we really looked at these early signals of this segment of older adults who are aging, what at the time we called unconventionally, Kevin, because it was weird that there's, a rugby league of 90-year-olds that older adults are like ditching the nursing home to go to a mosh pit of a heavy metal band that used to be their band, when they were teenagers, that they're DJs, that they're competing and spanking the young people in video game competitions, that there's grandfluencers, Kevin, who are making more money than I'll ever make, as Instagram grannies, that are becoming presidents of, countries at 70 or 80 or up there. So there's this one world of a frame of aging that used to be called unconventional, but it's becoming conventional, of words like vitality, dignity, health, agency. Remember the word Zoomer? That was coined in Canada by Moses Neimer. It was a boomer with zip, right? A very different positioning. But then the other tail, Kevin, is what a lot of us see, particularly in the median kind of income bracket, the average Canadian who's retiring off a Canada pension plan, maybe a little bit of supplementary pension, but they don't have the kind of cash flow. That cash flow is below the poverty line. And then you have a health system that can't meet their needs. So then that language is characterized by kind of a deficit model: pain, loneliness, sickness, dementia, poverty, right? And so there's kind of room in between those two for so much innovation to kind of meet Canadians where they kind of deserve to be in terms of how they age.
So tell us more about what you're seeing in so far as innovation goes.
All right, so much. So let's start on the health side. I'm a health futurist, so I kind of live in this world. And this is where things are going to get a little bit woo-woo for your audience, but I think it's important to hear it, Kevin. Okay, I think we're at a tipping point. So if you think of the growing prevalence and kind of demand for healthcare resources because of obesity, diabetes, and then, we call those all the cardiometabolic illnesses associated with that, cardiovascular, kidney failure, etc. And of course, then those things disproportionately impact Alzheimer's, right? So I think 40% of all dementia is linked to some of your kind of cardiometabolic health, not what you inherited from mom and dad and your genes. Mental health has been on a big rise, as you know. But I think we're at a tipping point and we're starting to see the data. And I would say there's, three big phenomenon in terms of what science can provide in innovation in the market. One, GLP-1s. The one brand that most people know is Ozempic. Shout out Canadian scientist Dan Drucker. He did the science that discovered what GLP-1s do right here in Toronto. And then, it got commercialized by the whole rest of the world. Unfortunately, not by Canada. But anyway, so we're now finally seeing obesity rates, which have been on the rise year over year since the 1950s, are denting down, Kevin. So I work with a scenario of what if we got to 1970s rates of obesity, which were like 10, 15%. Obesity underpins more than 70% of all healthcare demand. So I think that's a big one that could change the demand profile for care resources. Two, driverless cars. We're at that early stage. I remember when horse and buggy was still the dominant way and there was the odd Henry Ford car. But those curves are going to start to cross. And when they do, I think car accidents will be at the rate of airplane accidents. And that has huge implications for the health of the population. Accidents, depending on the country, are the third or fourth largest cause of both death and what we call morbidity, like illness and, pain. And then science. So we are in the AI age of science, where the old way was us humans had to... scientists had to set the hypothesis. We had incredible computing and data to help us do science really efficiently and fast. But the human is largely out of the loop. We're in this era of AI does the hypothesis, does the research, gets the result, and keeps iterating. And so the speed at which biology will move, which will allow biological medicines to move, it's going to make the last 200 years, which produced insulin, chemotherapy, HIV medicines, mRNA vaccine. It's going to make this look adorable compared to what's coming. So, there are some futurists and scientists who think the top 3 or 4 reasons people die or get sick will not be from biology. It will not be disease. It might be geopolitical, Kevin. It might be climate. Maybe it'll be loneliness, but it won't be because your body turned on you. So that stuff is kind of blows my mind. And if you want to follow more on that science, oh my God, I'm drawing a blank on the scientist out of Harvard, David Sinclair. Just listen to a podcast or get him on your show, Kevin, if you can. He's impossible to get for a podcast, but really the science is coming. So that's going to help. And then I think another factor is people's own awareness of the body and health, and that they don't want to feel unwell while aging. And COVID was a tipping point for that people had an awareness, because who did the worst during COVID? Our older adults who were already sick. And so the tools to self-manage your health are getting easier and easier to access. The awareness and the empowerment of people to not wait for the healthcare system to take care of us. We're going to take care of ourselves. I often say we're on the cusp of having 44 million healthcare CEOs, Kevin. Right? So I think those two together, I feel very optimistic about the health span of Canadians.
And this takes us back to your ageism comment up top. That's part of this too, isn't it?
100%. So again, people are self-declaring a different identity, and it's not being called weird or taboo or unconventional. It's becoming kind of normal. And then society itself as a kind of social constructs, language we use, imagery we use, who's getting put in movies. A lot of that is starting to shift the social construct away from ageism, which I think is going to unlock a lot of opportunity.
How would you describe the state of the Canadian healthcare system across the country today? You've described so much innovation moving so quickly. Can the system keep up?
Okay, so there's 2 versions of the system. The answer quickly is no. So there's 2 things the system can't keep up with. And this is any complex system, education system, our systems of democracy. So this is it's not a ding on healthcare at all. We set up a set of institutions that are kind of locked in and loaded based on a population's needs from the 1960s. So it's like we're trying to operate in 21st century healthcare on like a 18th century or 19th century operating model. I always say with my kids, like DOS operating system for trying to run an app store. So one cycle time disparity is my version of, can we keep up, is demand is growing exponentially for services, again, because we're staying alive longer. Our population is growing, and we're accumulating kind of illness, kind of at least that'll peak at 2040. And our system is designed to be very static, and it doesn't have enough buffer to meet that demand because it's very labor intensive. On the other hand, these tools are coming at a speed we've never seen, and nothing about our system was designed to absorb new tools, new methods, AI, all these things at the rate they're coming. And so it's like a double problem. The opportunity is right there to help address the issue, but our system isn't designed to embed it.
The reason I ask about the system is because, again, our listeners, the financial advisor, is in this unique situation where longevity is not entirely a good thing in terms of their ability to protect their clients' financial well-being. And I think I'm trying to get to a sort of key takeaway for them from everything you're sharing, I think it's that they need to understand and help their clients understand that the system is really going to continue to struggle to keep up even as we make progress. Is that a fair characterization?
Yep. Yeah. And that's been the pattern, by the way, for the last 20, 30 years of that. It's just the chasm keeps growing.
We talked so much about the healthcare system 10, 20 years ago. There was so much angst and so much conversation in political circles about what was necessary as the population aged. We knew what the baby boom was going to do to the system. Why did that seem to fall off? Like it was almost as though we just stopped talking about it one day.
It's interesting. I can see how you feel that. I don't feel that because I'm in it all day, and these conversations are still happening. And by the way, this is not unique to Canada. Like maybe there's 2 or 3 jurisdictions in the world that this isn't occupying all the oxygen, but everywhere else it is. Okay, so just to give ourselves some grace. So there's still a ton of study, talk, discourse happening, and a lot of work on this. It's not like anyone's sitting around going, there's nothing we can do. Man, there is innovation happening all the time, but it's hard to make a dent. I would equate it to kind of climate change and carbon. Like we're doing so many things, yet it's still getting worse, right? On many respects. So what I do find, though, why it might be not on your radar as much, or some of the advisors that you work with, is it's getting crowded out by a lot of other headlines or other urgent priorities. Most hospitals in this country are operating on a deficit, like a very big deficit. This was unheard of a few years ago. So that takes a lot of attention because our hospitals are like 30% of our entire healthcare budget. Clinicians as a workforce, and by the way, it's the 3rd largest workforce in Canada, our health workforce, nurses, doctors, physiotherapists, they're frustrated. They're at an all-time level of burnt out and kind of moral injury, worse than during COVID, Kevin. Okay, so that's a big deal. And then our wait times, like I said, are at all-time high. Our tax base is stagnant and we have no out valve. So these pressures are dominating the discourse. And so that doesn't leave room for creativity, generative thinking, and kind of long-range planning. And basically all those doomsday predictions about, the boomers, aging, and the demand implications it's going to have, they're now bearing out, and now we're in it, right? Versus trying to be able to step above and solve for it. It's really, really hard.
Is it just a question of volume for those healthcare workers, that the pressure is just that intense?
There's a volume is definitely one, but it's more. It's like, when you go to people can relate, when you've been in a job that it just doesn't work for you, things don't flow. The technology doesn't work for you. I don't know. You know what I mean? So there's just a lot of people just aren't at peace with their work. And the part of it is, healthcare is a calling, and you're called to care. And both because of the demand supply balance, you can't care effectively, or you have to leave people waiting. So that does have a huge moral, again, injury. But also you're pouring love on these humans at work, and the work environment is hard. And it's not, again, that there's bad employers or anything. It's just we haven't modernized our systems to make them work for the humans in it very well, and let alone the patients.
It's always fascinated me whenever I'm in a healthcare setting. It just seems a really difficult place to be, a difficult place to go every day. And do, as you say, what is for most professionals a genuine calling.
Yeah. It's a scary time, and I don't know. I can't believe, Kevin, we lasted like 30 minutes and we haven't said AI. But there's a reason why when University of Toronto scholar Geoffrey Hinton won the Nobel Prize a couple years ago for being part of the major discovery that led to some of the biggest advancements in AI in the world and changing the whole world, the first thing he said is what, he's most excited about is the impact on healthcare, right? And that's because we now have, for the first time in 30, 40 years of all these issues we've been talking about, something that could really change the labor structure that constrains access, right? We have to me, it's the equivalent of, do you remember phone operators, Kevin? When I do this with my students, they don't know what I'm talking about, but AT&T had estimated we would need as many operators, plugging in your phone and mine when I'm trying to talk to you across distance, as many phone operators as humans on Earth, okay? Back when we got to the agrarian age of agriculture, every human had to be a farmer because that was the only way we could create enough food for us to eat, is you had to produce your own food. Technology allowed surplus food to be created that led to cities and all those other things. Agriculture is a technology industry now. It is not a labor-based industry. When the switch technology came out, AT&T, that whole phone operator workforce was gone overnight. So this isn't about people lose jobs or whatever. This is about how do we get care to the people who need it and use the humans. And we have an incredible health workforce in Canada, Kevin, that other countries salivate how educated, how high quality our nurses, our doctors, our physiotherapists, our pharmacists are. Let them do the human stuff that humans do amazing, which is why healthcare is a human act. And my goodness, let the machines take the sludge out of the way. Our humans are doing a lot of sludge work in healthcare today that they should not be doing.
Are you more optimistic about AI's impact on the delivery of healthcare or research?
I'd say mostly delivery. Again, because we have an access problem. So to free up the human labor pool to meet people's needs who really need human care, that's why I'm the most bullish on AI. I think there are two other impacts of AI, maybe three, that I think are going to make a big dent. One is for sure what you said, science, which is going to just give us some tools to do things we couldn't do before. So that's amazing. But that's going to take a little bit of time, to get to the clinic, but it's going to be a game changer. The second, Kevin, is the population health level role of AI. So we've had very blunt tools to kind of look at a population and predict, how a flu season might play out. What's going to happen when there's a sedentary, built environment in a city, and what does that do to mobility and obesity and, children's mental health and all those things. We now can have an intelligence layer that the acquisition cost of the data to know in real time what is going on at a population level, that acquisition cost isn't what it used to be, which used to have to be like humans calling you, doing a survey, bringing you in, to study a population. We can get a barometer of the health of a population and predict risk and then mitigate. Instead of what we do today with population health is detect and treat. This is a very big shift of public health. So I'm very excited about what AI will do at a population level. This is kind of big data. Others might be hearing, oh, Zaina, you're talking about surveillance. That's not what I'm talking about. It's just an intelligence layer on a very old analog model of public health. And then the last area, which is probably where Zaina's the most excited, Kevin, has nothing to do with AI and our formal care systems. It's Canadians using AI to manage their own health. And so there's some incredible phenomenon happening that we're studying all over the world of people partnering with, an LLM to figure a lot of things out before they show up at the healthcare system's door. And I think that's going to be the biggest factor that's going to shift a lot of the profile of the things we've been talking about.
Tell me if this sounds right to you. I hear a lot of optimism in your voice and how you talk about this. I think the AI impact on the system and Canadians' health is tremendous reason for that optimism. But to bring it back again to the financial advisor and how they talk to clients about long-term planning, tell me if this is fair, that increasingly it's not going to be enough just to think about financial planning, that it's really about life planning, given all of the change happening in the world. Would you agree that there's a role for advisors to help their clients understand what's going on and how to think about their future differently?
100%. That's why I'm on this podcast. I'm like, wow, if some of this work can get to the outcome we all want through a wealth as the entry point, wealth management, I'm all for it. So again, lifespan, health span, and wealth span are inextricably linked. So by default, you're got to look at them in lockstep. Another thing I'd be thinking about too with financial advisors is hyper segmentation of your clients, right? So expectations around retirement, have drastically changed. So we've just talked about that, whether you're, poor, wealthy, and everyone in between. And so the decision-making processes of older adults surrounding how they want to live have followed suit. So how do you be ready to adjust and guide where there might be some gaps in knowledge? And I think, at CIMA, if you recall, just the lack of financial literacy, let alone health literacy, and kind of just basic planning tools is a very important lever. But nouveau literacy, not the old way, not brochures and you shoulds and watch this website, right? Hyper personalized. There's a whole phenomenon happening in the world of hyper personalized learning. Like the old model, our kids are going to be like, what? You were in a classroom with a teacher with 30 people passively absorbing knowledge? Like, that's not how we learn. So I think innovating on, those types of capacity building will be key. I'll just give you one example. Other countries have a personal longevity check like every 5 years from the age of 40. Wealth span, lifespan, health span, calibrate. What are we going to do? Like the tools to do that are very easy now, not like before.
My goodness, Zaina, I was so looking forward to talking to you, and you surpassed my expectations. Thank you so much. It's been a real pleasure.
Thanks for having this conversation, Kevin. Really important.
My guest has been Zaina Khayat. Visit zainakayat.org. Terrific website. Canadian Advisor Cast is a production of Newcom Media. It's produced by Alicia Hyatt. Yashin Ziafati is our associate producer. My name's Kevin Press. Thanks for being with us.